Okay, so now we're going to do a Q&A, and Vicky's going to ask some questions, and we're just going to go over some scenarios and why these things happen or why they don't happen.
So one of the questions was, what does the chirping mean?
Okay, so the chirping usually means that there's either an influx with the number that's set for the mean between the set number and your alarms. Um, we can kind of show this by that's saying that the number, as you can see, went down. So of course it's going to alert you that there's a leak of some sort. If I'm just going to manipulate this again. Again, if the number's high, that means that whatever you have it set to for your high is, of course, the number is reading above that number. So it's just alerting you that there's some type of something's happening. Either there's an obstruction, which probably means your high number is an obstruction. If it's low, that probably means that there's a leak within the system somewhere.
And then why does it spit water out?
Okay, so usually it spits water down from the green hose, and this is just condensation that is created from the humidifier into the baby, and then of course it's just expirated back from the baby. And usually you'll have some type of um, water spitting out of you from this cap. It's not dangerous or it doesn't hurt anything. It's just how the system's getting rid of extra water.
And what do I do with extra water in the tube?
You can, usually what I'll do is grab a paper towel. Usually the respiratory therapist takes care of this, but you can grab a paper towel. I usually hold it up as I'm going to show you. So I just take a paper towel, hold it up. You have to be careful of course, your circuit because it's very rigid. But usually I'll tilt the circuit up and down, and that usually will drain into the paper towel, and then of course you can dispose of the paper towel.
Should I clamp the tube when we're repositioning?
So the main thing is not to disconnect and or clamp the tube. There are certain situations where you have to, and sometimes, you know, if that means repositioning, the ultimate goal is not to, because you are going to cause de-recruitment in the lungs, meaning that the pressure is escaping the lung, and then when you have to hook that baby up, it's going to be harder for them, of course, to breathe because everything is clamped down. So the main goal is not to disconnect if you don't have to. Now there are occasions where there's lines tangled up and the baby needs disconnected. If that's the case, you need to make sure that you are using a gauze and a hemostat, and before you are ready to make this move, you have team members that know their roles and that everyone is prepared with, of course, the bag at the bedside in case something would happen. But the ultimate goal is not to disconnect.
How many team members should you have when you're trying to weigh or change position?
So usually depends to me a little bit on the experience of the nurse and the respiratory therapist. I say not by yourself at all. If you're going to reposition, you at least need to have the respiratory therapist and a nurse, and it doesn't really hurt to have that third nurse, and especially if you're changing linens or, you know, the sleep sack or anything underneath and need to reposition. I would say 3 would be optimal, but you can do it with 2.
What does a good wiggle look like?
So a good wiggle would consist of the chest area into the abdomen, and sometimes you'll actually end up getting some wiggle into the lower part of the legs. That would be a good wiggle. If you start to see that the wiggle isn't what it used to be. The first thing that you probably should do is go ahead and listen. Make sure that you have equal breath sounds, and that you can hear the oscillator on right and left side. Um, some babies wiggle more than others, and that just depends on how big they are. It also depends on the frequency that they're on and the pressure settings they're on. But if you initially, whenever you initially put the baby on the oscillator, you need to have observe somewhat of a wiggle, usually extended to the legs. If that wiggle does change, then you need to evaluate why that has changed. Either there's an obstruction, the baby needs suctioned, the tube, ET tube has either come out, so maybe the baby is actually extubated, and then you need to listen to the lungs, and I would also get an x-ray. Depending on what the situation is, if the baby's desatting, you probably need to make those changes a little faster, or if you really feel like the baby is extubated, then you need to probably extubate the baby and go ahead and bag them. But you need to call the nurse practitioner or the physician that's on call.
How often should you suction babies on the oscillator?
So to me, I try not to suction if I don't have to. Again, anytime that you are taking the pressure back out of the baby in the lungs, you're causing de-recruitment, which then it, of course, is going to drop your oxygen, and then you have to, that takes time to build that pressure back up in the lungs. Anytime that you're doing this, to collapse these lungs or these alveoli in these babies, especially preterm babies, you're hurting the lungs. So you try not to suction if you don't have to, but there are situations, of course, mucus plugs or thick secretions that may cause the tube to actually occlude, and then you have to suction. But I would advise not to suction if you don't have to.